Hi, everyone. Thanks so much for joining us today. My name is Hope Avalone, and I'm the Senior Manager of Patient Education Programs here at the Lymphoma Research Foundation. It's my great pleasure to welcome you to our webinar, Lymphoma and Military Service, Resources and Support for Veterans and Military Personnel. During today's webinar, you'll hear from 4 speakers, and we'll have time for a Q&A session at the very end of the program. If you'd like to submit a question, please do so through the Q&A box on your screen. We may not be able to address every question today, and not every question might be appropriate for this format, but we'll take as many as we can following the presentations. As a reminder, this webinar is being recorded. After the program concludes, you'll be prompted to complete a program evaluation, and we do ask that you complete this brief survey as we incorporate your feedback into future programming. Now, before we get into the presentations today, I'd like to just share a few brief words about our organization. The Lymphoma Research Foundation is the largest nonprofit organization that focuses specifically on lymphoma and chronic lymphocytic leukemia. Our mission is to realize the promise of science to eradicate lymphoma and to serve the community touched by this disease. And all of our work is led by our Scientific Advisory Board, which is a group of 45 leading lymphoma experts from around the country. In addition to today's program, the Foundation has many other programs and services available for you and your loved ones. We offer both in-person and virtual programs so that you can continue your learning throughout the year. I have listed the menu of our programs here, but if you'd like to view upcoming program dates, including upcoming programs for 2026, you can visit lymphoma.org/programs, which is updated regularly. In addition to our programming, the Foundation also offers a wide range of support services. Our helpline has master's level trained staff who can provide information on all types of lymphomas, as well as treatment options, clinical trial navigation, and connections to resources like financial assistance. We also offer a peer support program called the Lymphoma Support Network. And through the Lymphoma Support Network, we connect patients and care partners with others who have been through similar experiences for emotional support. The Foundation also offers comprehensive disease guides and fact sheets, which can be ordered or downloaded for free on our website, lymphoma.org. And please also look for us on YouTube, where we spotlight different lymphoma subtypes and treatment options. I'd like to quickly take a moment to thank our program supporters. Thanks to their generosity, we're able to host programs like today's webinar. But without further ado, we have a wonderful program planned for you today. I'm honored to first introduce our speaker, Brian Eggleston. Brian retired last year from his role as a portfolio director for international partnership covering aviation and maritime domain awareness integration, having previously served as the founding deputy director of a national effort to integrate aviation security information. His varied positions developed and implemented improvements to information sharing throughout government to create whole-of-nation unity of effort on aviation and maritime security. And this role followed 25 years in the U.S. Air Force and Navy. Thank you so much, Brian, for sharing your story with us today, and I will now gladly turn the talk over to you.
Well, thank you very much, Hope. Good afternoon, all. It's a pleasure to be here. I'd like to start off by thanking the Lymphoma Research Foundation and especially Hope Avalone and Dr. Kristen DeStefano for the opportunity to share my experiences and thoughts with fellow veterans and those impacted by lymphoma. So I am speaking to you today as a veteran of both the Air Force and Navy. I started out in the Air Force as a missileer, working on Titan II intercontinental ballistic missiles in underground silos before moving to the Navy for a career as an intelligence officer, during which I had multiple overseas deployments and assignments. In the course of my military service, I was exposed to a highly toxic agent that resulted in severe impact to my health. It first manifested as colon cancer, which was corrected by surgery. Then chronic lymphocytic leukemia was detected in follow-up monitoring in the months after that. While being addressed, the CLL caused what is known as Richter's transformation, which additionally resulted in small B-cell lymphoma, thereby compounding the challenge and complicating the approach to treatment. I had already undergone 2 immunotherapy trials for the CLL when another very new approach was offered for the small B-cell lymphoma. That involved treatment with a first-ever modification of the recently introduced VIPER regimen created by the National Cancer Institute, which has proved to be highly effective. Subsequent plan of care included a bone marrow transplant to increase the odds of long-term success. The cumulative result being that I am here today to convey a message of hope based on the recent advances that have been made in medical science and the caring skill of dedicated healthcare practitioners. I have this opportunity because of the insightful expertise and compassionate support of military medicine, in my case, provided by the Walter Reed National Military Medical Center and its various departments, in particular hematology and surgical oncology. Had it not been for the collective and seamless treatment by numerous specialists, the outcome would have been decidedly different. Care given by military medicine and the Veterans Administration employs unique insights into the risks of military service and specialized requirements for addressing that type of related health care. It was a VA doctor who first began to connect the dots on my exposure, and the VA continued to support in varied ways. For those who have had a similar experience and are still on active duty, I want to stress the importance of documenting toxic exposure prior to leaving the service. And for those who have already left the military, be aware of VA support, such as for presumptive exposure. National Service Officers, or NSOs, are available through veterans organizations, such as the Disabled American Veterans and American Legion, and they are really, truly an important resource. NSOs have critical insights and can help you navigate VA supports and claims. I'd like to share some personal observations made over the course of my journey in the event it may prove useful. Firstly, a collaborative approach to treatment has been key, as external providers were leveraged in offering additional options for care, while military medicine ensured collective unity of effort. Also, it's important to take an active role in your care. Communicate openly and honestly. Be informed, ask questions, and very importantly, advocate for yourself. I found it useful to prepare notes prior to my appointments that included a list of current medical observations and/or medications to bring to the attention of doctors, and also, most importantly, a list of questions to ask. Additionally, it was very helpful to take notes during those appointments. If possible, it's definitely helpful to have someone else take the notes while you maintain focus on the conversation with your healthcare provider. For me, this helped to maximize the outcome of each appointment. Be disciplined about following instructions during treatment. For example, taking medications at specific times, exactly as instructed, and make that your primary focus for daily routine. I certainly learned that during the execution of the VIPER trial. Everything had to be done at precise times and in exacting detail, but it certainly paid off. If you have multiple doctors and facilities involved in your treatment, help to ensure the sharing of records, test results, etc. For example, bring new data with you to appointments for timely inclusion. Keep your mind open for potential new treatments and trials, and not just for your primary medical concern, but also for potential side effects to treatments. Ask your healthcare team for their ideas. When the VIPER regimen was brought to my attention by Walter Reed and the National Institutes of Health, it was very new, and I was advised I would be the first to undergo a modified version. Keeping an open mind and weighing all options proved to be crucial. Be proactive. For example, get tests early if possible in consultation with your healthcare team. I just had a recent example whereby getting an early test proved to be decisive in getting ahead of a potential issue. So I found that to be critically important as well. Be cognizant of the importance of mental health along the way and how others have employed spirituality, meditation, support groups, etc., to help deal with challenges. Maintaining a positive attitude and approach to treatment proved to be a powerful tool. And for exercise, certainly within the guidelines of your doctors, incredibly important, also supports mental health and your all-important resilience. Caregivers are often family members, and they need support as well, as it is a shared journey. I can't imagine what my path would have been like on my own. And not just for the provision of emotional support, but for the individualized care when you're home. They are truly an essential element of treatment. Find ways to support continued research, including lending your voice and those of friends and family to advocate for necessary resourcing with your congressional and Senate representatives. The same goes for support to Veterans Administration programs. I want to express my heartfelt gratitude to the doctors and staff at Walter Reed, Johns Hopkins, and the National Institutes of Health for their incredible vision, expert approach to patient care, and steadfast individual support. And to the VA for all the help it provides to veterans across the spectrum of care. So in concluding, I want to wish you all the very best along your individual path of healing. Thank you very much.
Thank you so much, Brian, for sharing your story with us today and for really reiterating the importance of care integration as well as self-advocacy and also, the potential role of clinical trials in lymphoma care. So I am now thrilled to introduce our next speaker for today, Dr. Kristen B. DeStefano. Dr. DeStefano is a hematologist oncologist in the Air Force and at Walter Reed National Military Medical Center, where she is the fellowship program director and co-leads the clinical research team. Her research interests are lymphoma, epidemiology, and prevention. And before Walter Reed, she was at Travis Air Force Base in California, which has a joint DoD-VA Cancer Center. Thank you so much, Dr. DeStefano. And I'll now turn the talk over to you.
All right. Good afternoon. Can you hear me okay?
Yes.
Great. I want to thank the Lymphoma Research Foundation for organizing this important webinar, which honors a uniquely very special patient population, those who have served. I'm especially grateful to Commander Retired Eggleston for sharing his powerful story with us today. I first met him in 2019, and together we've navigated more than a few challenges. And truly, his perseverance and strength throughout this have been deeply inspiring, not only to me as his oncologist, but to us in the field. And it's patients like Commander Retired Eggleston who remind us why we do this work and motivate us to keep pushing forward. My talk is going to be short and sweet, and it's on insights into risk factors for B-cell non-Hodgkin lymphoma. Here is a disclaimer. So I want to first talk about normal B lymphocyte development. B cells are a type of immune cell that start developing in the bone marrow. They come from stem cells and they go through several stages before they're ready to fight infections. Early on in the bone marrow, they rearrange parts of their DNA. This is called a VDJ, stands for variable diversity and joining, rearrangements. And this creates a wide variety of antigen receptors. This helps the immune system to recognize many different forms of germs, even before they've they've seen any. Once the B cells meet something harmful or an antigen, they go to secondary lymphoid organs where they go through several stages. They get activated and they travel to a special place called a germinal center, which has two parts, the dark zone and the light zone. The dark zone is where B cells multiply and change their DNA to make better antibodies. And the light zone is where B cells are tested to see how well they can grab on to the antigen. If a B cell grabs an antigen strongly, it gets to survive and keep growing. If it doesn't, it dies off. So this process helps the immune system make the very best B cells to fight infections. And then after this, the B cells can become memory cells, which can fight future infections, or plasma cells that can make antibodies. And sometimes these memory B cells go back into the germinal center just to improve even more. So two important processes help these B cells get better at fighting germs. One is something called somatic hypermutation, where the B cells deliberately make small mutations in their DNA to help improve how well their antibodies work. And the other is called class switch recombination, where the B cells change the type of antibody they make to better match the infection. And both of these processes are controlled through a protein called AID, activation-induced cytidine deaminase, and that allows DNA mutations to occur on purpose. So it's almost like the B cells are editing themselves, testing new versions, keeping the ones that they like and discarding the ones that they don't like. And this is how your immune system is so powerful. This is normal. Let's talk about abnormal. So I do realize that there's more than 70 types of non-Hodgkin lymphoma. I'm only going to focus on the common types quickly. So if you'll notice, within a lymph node, within a secondary follicle, not only do we have the germinal center, but we also have this first mantle zone. And then we also have an area after the germinal center. Okay, so the mantle zone is where mantle cell lymphoma is derived. This starts from early B cells in the mantle zone. These cells have not gone through the germinal center, so they lack the key changes like somatic hypermutation and class switch recombination. Germinal center lymphomas include follicular lymphoma, Burkitt lymphoma, and some types of diffuse large B-cell lymphoma. And these come from B cells that are actively changing in the germinal center. They've already gone through somatic hypermutation. They have distinct mutations. Some types of diffuse large B-cell lymphoma can have what we call a dark zone signature, gene signature. And this is a highly unmet need because this subgroup of diffuse large B-cell lymphomas don't do as well. Then we have our post-germinal center lymphomas. This includes some diffuse large B-cell lymphomas and marginal zone lymphomas. They come from B cells that have left the germinal center and they become memory cells. So diffuse large B-cell lymphomas can hide from the immune system in multiple ways. And this is one way that the lymphoma can develop. So in terms of molecular classification, this is important because molecular classification sheds light into lymphoma initiation. Scientists have used genetic changes to group diffuse large B-cell lymphoma into different types. And these types are based on how the B cells developed and what mutations they have. Some types are easier to classify than others. And in this picture here, the color intensity shows how confident scientists are about each classification. So each genetic subtype has its own story shaped by when that B cell started changing and when the lymphoma very first started to develop. These early changes can lead to other cooperating mutations that can work together to help the cancer grow. This is important because in order to understand why some people get lymphoma and others don't, in order to understand lymphomagenesis, we need to understand the biology of the lymphoma to get an idea of these early initiating events that might have happened. So let's talk about some risk factors for B non-Hodgkin lymphoma. Increasing age for the most common B non-Hodgkin lymphoma, diffuse large B-cell lymphoma. The median age is in the mid-60s. Men have about a 20 to 30% increased risk over women. Non-Hispanic whites have the highest incidence. Family history is an important risk factor in a first-degree relative. There are something called GWAS studies, genome-wide association studies, that have identified certain parts of the genome that play a role in B cell development and immunity that may increase the risk. Certain exposures like pesticides and agricultural work, ionizing radiation, the risk depends on the dose and the duration of exposure. Certain infections like HIV, Epstein-Barr virus, hepatitis, and others. Immunodeficiency and autoimmunity. So this can include things like Sjögren's syndrome, lupus, immunosuppression, HIV infection, and then obesity is a soft risk factor. What about military service? Could that be a risk factor? Well, I love this topic because our patients truly are unique and special and different from civilians. People who have served while they're in the military, they're expected to deploy worldwide, go in harm's way, potentially serve in austere environments where there's potential exposures, stress, circadian rhythm disruptions. Also, the military has unique occupations that just don't exist in the civilian sector. To offset some of these risks, military members and veterans have very good access to care. While in uniform, they do regular physical fitness tests, mental health assessments, drug tests. And so this healthy soldier effect could potentially offset risks. I want to end my discussion by talking about two studies that have been done at Walter Reed. One is called Prometheus 19. So prevalence of monoclonal gammopathy among U.S. combat veterans deployed to Iraq and exposed to burn pits. So what we did is we took active duty service members only, not veterans, not people who did their 4 or 5 years and left the service and are getting their health care through the civilian network. We only looked at people who stayed in the military on active duty. And we looked at active duty who deployed to Iraq in the 2000s to either Joint Base Balad or Camp Taji. And we looked at those who deployed for 6 months or longer and who reported burn pit exposure on their post-deployment health assessment forms. And we looked at incidences of cancers and something in the blood called monoclonal gammopathy. This is a plasma cell disorder that's a cousin of B non-Hodgkin lymphoma. And the result of this study, which to me was really good news, was that there was no difference among service members who deployed and reported exposure after 14 years of follow-up. There was not increased incidence of lymphoma or monoclonal gammopathy compared with service members who did not serve in Iraq. Another study that is ongoing is called Prometheus 55, Toxin Exposure and Immune Dysregulation in Non-Hodgkin Lymphoma. This is a unique study in that it's being done between hematology oncology and allergy immunology. And we're doing a comprehensive assessment of deployment history, toxic exposures, military service history. We're looking at a comprehensive assessment of the immune system, and we're looking at genes that play a role in immune function to see if we can sort of uncover a rhyme or reason why some of our patients get lymphoma and others don't. Thank you very much. And that is all I have for you today. Thank you.
Thank you so much, Dr. DeStefano, for kind of laying the foundation for our learning and also for your efforts in convening this excellent group of speakers today. As a reminder to our attendees, if you have any questions, please submit those through the Q&A box on your screen, and any questions submitted can be made anonymous if you submit them through the Q&A box. But next up, it is my pleasure to introduce Dr. Helen Ma. Dr. Ma is a hematologist oncologist at the University of California in Irvine, where she is currently an assistant clinical professor in the Division of Hematology and Oncology. She also serves as an attending physician in hematology and oncology in the VA Long Beach Healthcare System in Long Beach, California. And as the Stephanie A. Gregory Distinguished Scholar, Dr. Ma received funding from the Lymphoma Research Foundation, which contributed to her investigation of the association between military exposure and the development of lymphoma. Since her grant period ended, she has remained involved with the foundation through our Lymphoma Rounds programs, as well as our scientific initiatives and workshops, and now with our patient education program. So thank you so much, Dr. Ma, and I'll now turn the talk over to you.
Thank you so much. Thank you to the organizers and Dr. DeStefano for inviting me to present to you today. Again, I'm Helen Ma, I'm a doctor at the VA Long Beach and UCI. I don't have any disclosures to report. And today I'll be discussing lymphoma research at the VA. So following Commander Retired Feigel's inspirational clinical story and Dr. DeStefano's tutorial on lymphoma, I've been asked to talk about some of the lymphoma research we're doing at the VA, as well as how to obtain a toxic exposure assessment. So to begin, one of our more recent studies is about polygenic risk and Agent Orange exposure risks in the development of lymphoma. So by way of background, we have the VA Million Veteran Program, which you may have heard of. That we've enrolled over 1 million US veterans, where we collected self-reported MVP surveys where you can talk about your lifestyle, military exposure and history, as well as medical history. We can link that to the VA medical records if you are enrolled in the VA. We have patients who give a blood sample to impute whole genome sequencing so we can learn more about your genetics. And then we can also link it to non-VA sources like the National Death Index. If people have passed away, we can see their causes of death, the Centers of Medicare and Medicaid, as well as the Department of Defense. And so in this study, we looked at something called the genetic by environmental, a G by E study, where we looked at risk gene variants, where in your genetics, like Dr. DeStefano had mentioned with GWAS studies, where we have patients with high risk gene variants that are published in the literature, as well as Agent Orange exposure by self-reported surveys. We identified cases in the VA Central Cancer Registry between 1965 and 2024. It was restricted to non-Hispanic white veterans, which really underscores the importance of having diverse populations enrolled in research, just so that we can be more representative of our populations. But what we found was there's an increased risk of lymphoid malignancies in veterans with higher genetic risk. So this has been published in the literature. This was just a really good internal validation for our study that what's been published out there is consistent with our veteran population. And these, with genetics, we can't really change that. And that was important to show. In terms of CLL, there's an increased risk, diffuse large B cell, follicular lymphoma, marginal zone lymphoma, and multiple myeloma. And our second part of the study, we looked at Agent Orange exposure by the survey results, and it did show that there was an increased risk of lymphoid malignancies in veterans with Agent Orange exposure as well. And we see that the blue dots with the Agent Orange exposure is consistently higher than those with the Agent Orange unexposed. And this was true even after multivariate logistic regression, meaning we took into consideration age and sex and gender. Sex and any other confounders that might be contributing. Marginal zone lymphoma is a smaller population, so it did lose its significance, but the amount that it had increased risk was still present. So looking at the conclusions, there is an increased risk of lymphoma in veterans with a higher genetic risk, which is consistent with what's published out there. And for the first time, we were able to show that there is an increased risk of lymphomas in veterans with Agent Orange exposure by certain subtypes. And so now moving on to Agent Orange exposed veterans with lymphoma in terms of their outcomes and survival. So we did a case study looking at patients with lymphoma using the VA medical record again, where we had Vietnam veterans who served between 1962 and 1974 when Agent Orange was used. And we looked at incident cases, meaning new cases of lymphoma. And the Agent Orange assessment at this point was whether they had a VA disability assessment, meaning in the chart whether they had an Agent Orange service-connected medical condition such as lymphoma. The limitations to this, though, is that we restricted to veterans who enrolled in the VA. Of course, we didn't have data to private insurance or those with active military, and a survival bias, meaning these are limited to veterans who have lived long enough to enroll in the VA. So those that might have developed the lymphoma and died before they were able to enroll in the VA were not included. And so we had mostly men, so we restricted it to the male population in this particular study just to keep the biological differences restricted. And so we found that the age at diagnosis was an older population. We had mostly white veterans, but we did have a pretty good diversity. And we had many different subtypes of lymphoid malignancies that we included, like Burkitt's lymphoma, CLL, cutaneous T-cell lymphoma, diffuse large B-cell lymphoma, et cetera. And so these graphs all just kind of show you that there was not a difference. So survival among Agent Orange exposed veterans was not worse than those that were unexposed. And these were just graphs to show you that they were all pretty consistent. And it was interesting to see, at least in terms of the aggressiveness of the disease, you can see how survival is definitely changed by whether you have a more aggressive types. Like diffuse large B-cell lymphoma was worse than chronic lymphocytic leukemia and follicular lymphoma. So in terms of that, that was a good internal validation of overall survival in these populations. So the conclusion in this was that there's survival among Agent Orange exposed veterans was not worse than unexposed in all and across subtypes. But of course, there are limitations, such as the selection bias I mentioned, where there's only veterans enrolled in the VA, and survival bias, where only veterans who survived long enough to make it to the analysis was included. And finally, our third study I wanted to talk to you about was treatments in veterans with CLL, chronic lymphocytic leukemia. And so this one was a retrospective, again, using the VA Cancer Registry. We identified veterans diagnosed with CLL and treated in the VA system over 20 years. And we categorized CLL therapies as chemoimmunotherapy, such as chemotherapy, regimens like fludarabine, cyclophosphamide, rituximab, FCR, or targeted therapies like ibrutinib, acalabrutinib, zanubrutinib, venetoclax, and monoclonal antibody such as rituximab or obinutuzumab. And we found that throughout the years, this is just a stacked bar graph where it's 100% and the x-axis is the years. And so from 2000, most patients received chemotherapy, some with just monoclonal antibody alone. And then over time, we see that the green increases with chemoimmunotherapy when we know that the addition of a monoclonal antibody like rituximab improves outcomes for patients. And then from 2013, 2014, we see the introduction of targeted therapies like ibrutinib when it first came on board, increasing, and now basically all patients basically get targeted therapies in accordance to the standards of care and our guidelines. So to conclude, the treatments for CLL at the VA are consistent with evidence-based national guidelines, both like NCCN as well as our VA guidelines. So next, I'll transition to how to obtain a military risk assessment at the VA. So of course, enrolling in the VA and talking to your doctor about your concerns about exposure is really important. At our VA, we have a military exposure and occupational health where we can put in a referral where our trained physicians and NPs can do an assessment. And I've talked to our chief of occupational health who kind of walked me through how she would go through an assessment. And basically they have a structured template where they would look at various things such as, introducing you to the concept of all of this, looking at your military history and exposure assessment, of course, getting your history of present illness and review of systems to see what symptoms you're feeling and how you're doing overall, going through your medications and your medical history, as well as social history, family history, and then physical exam, and then kind of concluding all the information that they went over with you. So things like this could be, making sure that they account for your exposures of concern, whether you're going into a non-registry or a registry exam. In terms of Module 2 with the military history, you'll see that they'll have reviewing with you the individual longitudinal exposure record, which you may have heard about, as well as the military deployment history in the Veteran Benefit Management platform. And these are really important because they're unique to you and you can document your individual exposures. And then, of course, talking about periods of service. Here, they'll also talk about deployment-related exposures and the registries that are available you can join. So there's the Airborne Hazards and Open Burn Pits, Gulf War Registry, Agent Orange Registry, where you'll have surveys to fill out very detailed information about your exposures as well as your medical history. And then there's even more unique exposures that you might not hear about, like garrison-specific environmental exposures, Camp Lejeune, the Fukushima nuclear accident, etc. So it gets pretty detailed in terms of at least placing you in these places. Unfortunately, we don't have the actual, measurements of the exposures you have, which will always be a limitation when we're looking backwards to get this information. And then other military exposures that can lead to health effects, as we know, like asbestos or fuels, exhaust, solvents, lead, things that we know have health effects. So that's my section of it. Thank you for your attention. And again, I'd like to acknowledge the LRF and inviting me to speak to you today. Thank you.
Thank you so much, Dr. Ma, for your presentation. And last but not least here, I'm so honored to introduce our final speaker, Dr. Drew Helmer. Dr. Helmer is an expert in the effects of military exposures and deployment. He is the Deputy Director of the Center for Innovations in Quality, Effectiveness, and Safety at the Michael E. DeBakey VA Medical Center and Professor of Medicine in the section of Health Services Research at Baylor College of Medicine in Houston, Texas. And in addition to caring for veterans and educating providers, researchers, and trainees, Dr. Helmer studies healthcare utilization and outcomes important to deployed veterans, including chronic multi-symptom illnesses, military exposure concerns, mild traumatic brain injury, and sexual health concerns. He has published more than 130 peer-reviewed scientific articles and a book as well for a lay audience on these topics. So thank you so much, Dr. Helmer, for being here today, and I'll now turn the talk over to you.
Thank you. You can hear me and see the slides?
Yes, sounds good. Look good.
This is an honor to be here and to be presenting to you with these wonderful colleagues. And I want a special shout out to Commander Eggleston there. A lot of what you said really resonated with me from my provider perspective. And what I'm going to do today is talk a little bit about the concepts of association, causality in general, and then how the VA kind of looks at assigning or attributing that causality to military exposures for service connection. And so this is a challenging topic, and for many people. It's often a challenge for clinicians to speak to these issues in the context of care. I advocate for honesty and clarity and admitting when you don't know the answers. And I also think it's probably timely. There's a recent series in the Washington Post about service connection that uncovered or kind of discussed a lot of the challenges and maybe came to some conclusions that not everybody agrees with. I hope that I can avoid some controversy here, but I also want to make sure that any veterans or veteran caregivers on the call have some more information about this topic and a better understanding of what they can do next if they're looking for help in this way. Let me see if I can advance the slides here. Okay, I don't have any disclosures really, and I, of course, am representing myself, not the federal government. So there are a ton of challenges in what we call military exposure research. Dr. DeStefano kind of already addressed some of these. Dr. Ma and her describing her work also touched on some of these challenges. I want to make them very clear. when somebody is in the military, they are in harm's way and they are exposed to many toxic substances almost as a matter of routine. Whether that's environmental exposures, the air quality, the water quality, soil contamination, those things are common in domestic US bases, as well as foreign bases and in war zones, and in combat zones. And so there are multiple exposures in addition to the environmental exposures, there are occupational exposures. So depending on what you do for the military, or even if it's not your assigned duty, the tasks that you're assigned to do may expose you to petrochemicals, solvents, firefighting foam, which contains the forever chemicals, the PFAS, the PFOA. And then, of course, that combination is very hard to detect while it's happening. And then there's what's happened before you join the military. And for many people, the years that you are after you're separated from the military, all of those things kind of create this idea of the exposome, the exposures that we all encounter and that get into our body and can interact with our genome and cause health problems. Well, when we think about military exposures, or just in our daily lives, most of us don't go around assessing the air quality that we're breathing. You know, we may look at the air quality index for our city or our region and kind of glance at it and be like, oh, this is going to be a bad pollen day. But we don't actually measure the level that goes into our lungs. The military doesn't do that either, except for certain occupations. If you're working in a setting with ionizing radiation, you'll have a dosimeter, and that would be measured. But there's not a lot of individual level or direct exposure assessment. Another challenge with a lot of the conditions that we worry about from these toxic exposures is that they're latent. That means that they don't happen immediately, and they don't even necessarily happen and then kind of just gradually get worse. There's this period where they're silent. The effect has happened or it's been triggered, but it doesn't actually get to the point of clinical manifestation. We don't see it until later on. And that makes it very difficult to draw a line between this condition and this exposure. On top of that, a lot of the conditions that we worry about, especially the cancers, lymphomas, are relatively rare conditions. And so when you think about the numbers of people, like if it happens in 1 in 100,000 people, you know, if you want to see 2 of these and you expect to see 100, you know, 1 per 100,000, you need 200,000 people in the sample, in the population to see that. And if you want to see a difference between 1 and say 3, statistically, you need a pretty large group of people to figure that out. Finally, another major challenge with the military exposure research is that when you're in the military, yes, you get care from the military health system. You know, that may be actually at a military treatment facility, or it could be out in the community. So that's a little bit of fragmentation. That information does generally come back to the Department of Defense, though. But then when you separate from the military, not everybody goes to the VA. I work for the VA. I advocate for patients to come to the VA. I think when you're in the system, it's very good in the sense that it's integrated and coordinated, and there's good communication through our electronic medical record, and it can be comprehensive in nature. But even then, people sometimes find that they need to get some of their care outside the VA, and that fragmentation can lead to missing information about a condition. And so if you're trying to do the research, it can be really difficult to draw those connections. So one of my conclusions, and I work very hard to improve military exposure research. It's one of my major jobs in the VA is to accelerate, you know, high quality military exposure research and help people access, you know, the data and the biospecimens they need to do this research. I'm not super optimistic that we'll really be able to definitively establish causal relationships between certain toxic exposures and certain conditions, especially rare conditions. We really need to think about prospectively studying these things, and that's expensive, and it also takes a long time. So we do our best. We do our best to answer the question about, is this health effect related to this toxic exposure? And in order to do that, we use something called the tenets of causality. These are epidemiology constructs that were kind of put down on paper by Sir Bradford Hill back in 1965. I'm not going to go through each one of these, but I want to highlight a couple of them just to underscore the importance of thinking systematically about causal relationships, about this causing that, and how that can affect our understanding of military exposures and health outcomes. So, first of all, one of the most important ones is there an association? Like, if you look at this at kind of face value, is there a higher rate of the disease in the population? And then when you look at and kind of compare to a non-exposed group, do you see that there is enough of a difference to be compelling? So, this is certainly not enough information to make a decision about whether the disease is related to the exposure, but it's really important. So if you see a very high difference between two groups, one exposed, one not exposed, a little alarm bell needs to go off, and of course that's what we do. You also want to see that it's consistent across groups and over time. And if you can, you want to narrow it down to, is there an obvious cause? Like, if you see an elevated association and it's in multiple groups, but you can't draw a line between the groups in terms of the similar exposures. This group was exposed to toxin A, this one was not exposed to toxin A, but exposed to toxin B. You have to kind of think about, is that the specific cause? Two other things I'm going to highlight here is, one is the temporality. It is often very difficult to know whether the exposure comes before the health outcome. Sometimes it seems obvious, like if you were in the military and you were exposed to this, while you're in the military, and then you don't get the disease until later on. Obviously, the disease came after a military exposure, but you don't really know about all those other things that happened in between that exposure and that health outcome. And sometimes it can be very confusing, like, is it really happening after the exposure, or is there something else going on with that exposure? And finally, we use this concept of a dose response. So for many things, a low dose may raise your risk a little bit, but a higher dose is going to raise your risk a lot. And so we do rely on that, in terms of making this determination about causality. And that, of course, is what underlies our whole concept of service connection. I do want to take a little bit of a detour here. I'm not directly involved with the missile community cancer study, but I have been reading up on it, and I heard a couple of presentations at a meeting not so long ago. And I do want to highlight it because of the concern about lymphoma in the missileers. This is actually, in my opinion, one of the best designed studies, and one of the best examples of good communication around a research study that I've seen in a long time. And I think, there are some obvious challenges. I think the people doing the research have done a very good job of sharing those challenges and trying to figure out how to address those challenges and move forward and do the best research they can. I think a couple of things that I took away from what's been published so far with the results from phases 1A to 1C are that, it is not just ionizing radiation, that there were, once again, multiple contaminants of concern, and diverse contaminants of concern, and difficult to actually pin those down. Right now, based on the results, it does appear that the association is kind of weak. That there's not a lot of strong evidence of association between a location or a specific job category and cancers. As a matter of fact, some of the cancers, they seem to be lower incidence in the missile community, and that could be because of that healthy warrior effect that Dr. DeStefano was talking about. And of course, the phase 2 results are due any day now, and like I said earlier, it's a very strong study design, and I really like the approach, but of course, there are still limitations. Getting back to the service connection question. So this is run out of the Veterans Benefits Administration, a whole kind of branch of the VA Veterans Administration focused on this. And the idea here is that they're fulfilling the, our social contract with military personnel that you go to war and we're going to take care of you. The benefits include, of course, health care from the Veterans Health Administration. That's that comprehensive integrated care that Dr. Stefano also talked about, Dr. Ma talked about, the military environmental exposure assessments. This is the sort of, I work for the VHA. I do those exposure assessments and take care of veterans. But the VBA also covers disability payments, education, training, and vocational rehabilitation, home loans. And so there's a whole plethora of benefits that are available to veterans based on their eligibility. So eligibility for many of these things is based on having a disease or a condition that was caused or exacerbated by military duty. You have to, the term is establishing that nexus, that connection. A real important thing here is that it's based on a disease or a condition. It's not based on an exposure. And I do see that patients get confused about that. They're like, I was exposed to this. It's about the disease. And sometimes that disease is named very specifically in the regulations, and sometimes it's more broadly termed, but sometimes a specific disease gets not included in there. And it's not just about the exposure, it is about the disease. So when we have a delayed or invisible wound, it can be very difficult to connect it to military service. So cancers are a perfect example of this latent or delayed health problem. The invisible wounds are, the toxic exposures and the damage that they do are certainly invisible. We really don't have a good way of ascertaining the damage that's done from most toxins. And that makes it very difficult to do this connection or creating that nexus. So in recognition of that, after, well, even before the Vietnam era, but certainly Agent Orange became a very big problem. And, in response to the concerns about Agent Orange and its dioxin, this presumption really kind of became a more commonly used approach to fulfill that social contract that I was talking about. So they will presume that if you were in a place during a time period, you were exposed to a particular toxin. That's critical because nobody measured, that the concentration of that toxin that came into your body. So that exposure is presumed, and then Congress or the Secretary of the VA can say, based on that presumed exposure, here are the diseases or the conditions that we think should be service connected. And in order to make that determination, they don't require that the research be done in the military population. It could be done in other similar groups of people, non-military or people in the military in other countries or something like that. So they will cast a broader net to try to find the scientific evidence supporting that causal relationship. And then, of course, the Sergeant First Class Heath Robinson, honoring our promise to address Comprehensive Toxics Act, or the PACT Act of 2022, really was peak social contract in the sense that it really expanded tremendously the list of service-connected conditions that were presumed related to various toxins, especially for people in the Gulf War of 1990-91 or to date, with a few service-connected conditions added for Vietnam veterans. Importantly, it also created a new process for nominating conditions to be considered for presumed service connection and how that assessment is done. It kind of expanded the limits, if you will, of how the VA can actually make that determination and the evidence they can bring to make that determination. And that link there is to the report that describes that process. So now specifically about lymphoma. a service connection for lymphoma. So non-Hodgkin's lymphoma is presumed service connected for Vietnam veterans because of evidence supporting an association between dioxin and non-Hodgkin's lymphoma. And then the PACT Act of 2022 established, quote, lymphoma of any type as a presumed service-connected condition if you were in these places, I'm not going to read that, during those time periods. And that's it. That's the law that says these people are going to be service-connected or could be service-connected if they apply, submit a claim for lymphoma of any type. I will say, you just heard a couple of presentations by my colleagues, Dr. DiStefano and Dr. Ma, that the evidence supporting an association between lymphoma and certain specific toxins may not be very strong. The PACT Act bypassed that vetting by scientific evidence and just said we're going to write a law that says this is going to happen. And so that those tenets of causality that I talked about may or may not be fully met for lymphoma being associated with toxic exposures during military service. It doesn't matter at this point. The law says that those are going to be service-connected conditions. The flip side of that is if you are a person who wasn't in one of those places during those time periods, you do not have that presumed service connection. And that is a limitation. You can still apply for service connection, but you have to make the case in your claim or your application that because of either some exposure or some other event or experience that you think you have that nexus and you can make that connection. So I have a slide here that has a couple of the resources where you can go to submit a claim. Commander Eggleston made some really good recommendations about working with a national service organization or a veteran service organization and named a few of them. It's really important to work with somebody who has experience with these, especially if you are interested in moving this forward, moving your claim forward quickly and being successful. Having somebody experienced is very helpful. And so hopefully, some of those resources will be helpful to you. And I think at that point I can stop for questions.
All right, thank you so much, Dr. Helmer, for your presentation. And like you said, we'll now take a few questions with the time that we have left today. Again, if you'd like to ask a question, you can submit them through the Q&A box on your screen. So I'm going to start off with a question or combining a few questions here for Dr. DiStefano. I know Dr. Helmer just mentioned PFAS are forever chemicals, and we have a few questions here still about them. Dr. DiStefano, would you be able to reiterate if there is a known association between these forever chemicals and lymphoma?
Yeah, that's a really good question. And that's a question that comes up a lot. And I'm curious to hear if Dr. Helmer and Dr. Ma have any thoughts on this. Offhand, I'm not aware of high quality, good, convincing data. A couple months ago, I did read a published report. I'm blanking on the name of the journal, but it did say something about, up to 50% of American home drinking water containing PFAS. And so it's a big problem. I'm not aware of a link with lymphoma. And if there were, I'd be curious what level of exposure and what duration of exposure. And in the individual person, is there something in their DNA that makes them more susceptible to the effects of the exposure? For example, do they have a hard time with DNA damage repair or, repairing like free radical stress or something like that? So I'm not aware, but like I mentioned, we do at Walter Reed and Bethesda, we have a study called Prometheus 55 that is actively enrolling patients with any lymphoma at any point. You can be a survivor, you can be on surveillance, you can be untreated, you can be treated, all B-cell non-Hodgkin lymphomas. And we're looking at immune function and exposures and genes. And so if you're interested in that, we're trying to get answers to these questions. Hope can connect you with me offline.
Thank you so much.
Oh, sorry. I'm not aware of any association with PFAS, PFOA with lymphoma, but when I did my environmental health master's at UCI, Dr. Bartel is a PFAS expert, and he did share a review on kidney cancer and testicular cancer that's been associated, but not with lymphoma that I'm aware of.
Yeah, and I just want to highlight, that there is this challenge. I mean, first of all, you have to look, right? You have to look to see if there's an association. It doesn't just come out and wave at you and say, hey, we're connected to this. And it does take large numbers of people to really make these determinations. And so what I tell patients, when I'm evaluating them and that they ask this question, was this caused by that? I'm like, I'm not going to tell you no. I'm never going to tell you no. But I'm going to say that we don't have strong evidence yet. And I will also tell you, we don't have any evidence yet, that it is or is not related. But I think then it becomes, how can we get the evidence? And that's where, you need Dr. Ma and Dr. DeStefano and others to do the research and help to figure that out.
Thank you all for chiming in, and please do continue to share any insight to any question that I read out today. So the next question here, I'll start with Dr. Ma. Are there any studies comparing Vietnam veterans, boots on the ground, compared with Vietnam era veterans for rates of cancer or rates of lymphoma?
Not that I'm aware of, but it could be something we can do. So you could reach out to me and I'll include you in the study and we can figure out the way to do it together.
I think that's great to hear. And I think I have another question here for you, Dr. Ma. Is there more information available about the VA Central Cancer Registry that you mentioned?
In terms of
I guess someone is just asking if they just asked generally if there was more information about it. I don't know if you can just reiterate what you said or speak more generally to it.
Oh yeah, so with a lot of cancer registries, we have certified registrars who are experienced with looking at patient medical records and then extracting important details that are in alignment with registry data collection. So that usually it's a standardized format so that we could share information across multiple databases, kind of like SEER and things like that, if you've heard of it. So it's within the medical record, and I do my analysis in something called Vinci, which is like a VA informatics virtual machine that doesn't even have internet, so that it's really secure, and then we do our research analyses that way. But I'm not sure if I'm answering the question.
Let
I
me
think
chime in.
so.
Let me chime in a little bit about the VA Cancer Registry. Like Dr. Ma said, so it is the VA's version of a cancer registry, and it is national in scope. And so that makes it very useful to researchers because, like she said, we have people who are paid to go in and put in the information that's important to understanding the cancer and to understanding the outcomes of the cancer and which treatments were used. Most states, I think maybe all states, but certainly most states have their own state-based cancer registry, and most states and the VA participate in kind of a shared national registry in order to allow the research. Because like I said earlier, a lot of these cancers are pretty rare, and you really need that kind of combined effort to start to tease out the answers to some of these important questions. So in terms of like, how would you know more about the VA Cancer Registry? There was a publication like in 2017 that you could find in PubMed if you use that as a source, or you could do Google and put in VA Central Cancer Registry, and it might come up. And that kind of describes the how the cancer registry works and some of the overall findings. I'll also put in a plug for the VA there. The cancer registry is still important. We're still maintaining it, of course, but there's actually another registry called the National Precision Oncology Program, and they are tracking cancers that are and the genetics of the tumors. And so that's going to be another great tool for understanding some of the details of what might be causing the cancers, what some of the contributing factors are, how they respond to treatments, which treatments might work for them. And so I think that National Precision Oncology Program is also very important.
Thank you so much. Dr. DeStefano, did you have something to add?
I
Yeah.
have one thing to add. This is something I'm really excited about. As everyone knows, a lot of service members do their 4 or 5 years, leave the service. They may or may not get their health care through the VA. They may or may not get their cancer care through the VA. And so the DoD or Department of War Cancer Registry and the VA Cancer Registry might be missing some cases. And so there is an effort underway to combine the VA Cancer Registry, the Department of War Cancer Registry, and civilian state cancer registries to capture all cancer data on anyone who has served, even if they're not getting healthcare at a military treatment facility or at a VA hospital. And that's really exciting. And I think that's coming soon. Over.
Thank you so much for the additional input on that question. And the next question here I'm going to direct to Dr. Helmer, but of course, everyone feel free to chime in. The question reads, I worked in the Port Mortuary at Dover, Delaware AFB for 10 years. Is it possible I had any toxic exposure there? And could you speak a little bit more about occupational hazards?
Yeah, I guess I'm going to interpret that as this, they were working in the mortuary service, and so we're probably exposed to some of the embalming chemicals and perhaps other toxins that might have been associated with either processing the remains or that came in with the remains. So, I would need more information about what you did, the protective equipment that you used, the ventilation in the space, how long you were there. All of those details are important in terms of kind of creating a tailored risk assessment for the individual. I also would say I need to do a little more research into which chemicals are typically used, and either the patient could tell me that, or I could go online and try to look it up and find out more about that. And then I would have to then make a determination about, okay, so what is known about these chemicals and their short and long-term risk? And then how much of these chemicals were you exposed to, and maybe what other factors might contribute? Personal behaviors like drinking alcohol and smoking cigarettes obviously raise your risk, but sometimes in combination with other toxins, your risk goes up exponentially. So those are other important things to keep in mind. I do think that exposure, being in the mortuary is certainly something that, Dr. Ma talked about the military environmental exposure assessment. So if you're able to go to a VA and request that, I think that would probably be a good use of that service that the VA offers. They do offer that both in person at certain facilities, and then there's a kind of a telehealth option for that as well if your local facility doesn't have that available.
Thank you so much. And I do have another question for you, Dr. Helmer. So this participant says they're 100% disabled through the VA, and they've been on ibrutinib and acalabrutinib for the past 7 years. So they get these meds from a specialty pharmacy, and they're wondering, and maybe in general, can the VA reimburse for monthly copays for medications?
So I don't want to give you the wrong answer. So I'm going to say maybe, and maybe the answer is even probably, but I think it's one of the tricky things is probably how do you make that happen? So typically, as a VA physician, if I prescribe something, the VA will pay for it, right? And you wouldn't have, if you're 100%, you wouldn't have a copay. If you're getting it through community care, you should also not have to pay a copay. If you're doing it on your own outside of the VA, what I think you need to do is kind of bring it back into the VA in order to get it covered. And so I think, that could be just going to a primary care provider and saying, I'm in this phase of my treatment and I need somebody, they would refer to an oncologist or a hematologist in the VA in order to make that, I'm sure. But I think that's how you would do it. And I see Dr. Ma has her hand up, so she's probably got the answer.
Yes, exactly. So I do see cancer patients at the VA, and we do co-manage, meaning you definitely can keep seeing your outside provider. And then once you establish with us and you have service connection, then we can, prescribe the medication for you. We do insist that obviously, since we're prescribing, that you do have regular follow-up, get labs with us, since we're ultimately responsible for any side effects and things like that. So it would be a co-management system, meaning you'll see both providers, but veterans have been very grateful that they can get their medications for free in a situation similar to yours.
Thank you, Dr. Ma. And I'm going to follow up with another question for you, actually. What is the role of antibody affinity maturation in B-cell lymphoma treatment and its monoclonal antibodies?
Is that for me or for Dr. DeStefano?
Both of you can feel free to chime in as our resident hematologist. So Dr. Ma, if you want to get started, or Dr. DeStefano, doesn't matter.
I mean, I think in terms of the targeting, it targets the B cells, and it would be not that specific since immature B cells can also express CD19, CD20. So that's why we sometimes have, neutropenia, meaning you have a decreased immune system and you can get a higher risk of getting infections, just because unfortunately there is a bystander effect where we're also sometimes wiping out your good cells in your immune system while we're trying to target the lymphoma. Did I answer that the way that they intended? Or Dr. DeStefano, anything you want to add?
What I would add, no, I thought your explanation was fantastic. What I would add is that I think it's going to really be important for something called circulating tumor DNA. Monitoring, surveillance, meaning a blood test to look for traces DNA from your lymphoma. I think that is where knowing all of the mutations, exactly what went wrong during that affinity maturation process, what specific VDJ rearrangement clone does your lymphoma have? In other words, what is the fingerprint of your lymphoma to be able to monitor to see if it's still there? I think that's where I see that being really important in the clinic. Over.
Thank you both. And I think we're going to have time for just two more questions here today. This next one, I think mostly will be for Dr. Helmer. I think it's just something that he can address more generally. So the question we have here is that the VA has denied my claim for NHL based upon a presumptive exposure to Agent Orange. Do you have any advice for someone whose claim was denied?
Trying to get off mute there. Yes, keep trying. Because I have seen it happen many, many times that somebody gets really an obviously incorrect determination, and then they resubmit and it's reviewed. This is where having an expert person, and maybe Commander Eggleston, you want to comment on this too, but having an expert claims helper would really be important, because you can reopen claims versus appealing claims, and that makes a difference in terms of how it's handled. So definitely talk to an expert about it. What I think I can say about your particular circumstance is if it was denied because it's presumed service connection for people in certain locations during certain time periods. And so if you either can't prove that you were in one of those locations at one of those time periods, or you weren't in those locations during those time periods, you can't do it through the presumption process. And you have to establish the nexus yourself. And I have seen this with people who say, I was in some other place and there were barrels of Agent Orange and they told us it was Agent Orange and we used it, this sort of thing. And they had to kind of make a pretty strong effort to document that there was Agent Orange where they were and that they were interacting with it. And they had to do it through the individual claim, not under the presumption. So that is a very high bar, and it can be very challenging. I have seen a few people kind of make a strong case that, and provide some documentation either from a fellow service member or from kind of an officer that was at the location at the same time, a letter of attestation, if you will, that supports that claim. And so that's often how that will move forward.
Brian, if you want to chime in, I see your hand is raised.
Yeah, I just wanted to reinforce Dr. Hilmer's comment on getting an expert involved or experts. Do your research, do your homework, and then take what you've put together and take it to a national service officer at whichever one of the veterans organizations you prefer. And they are specifically trained to know the ins and outs of the system and to give you solid advice.
Thank you, Brian. And the last question for today, we'll start off with Dr. Ma, but I know there will probably be a lot of thoughts on this. Are you or other colleagues working with AI tools to aid in your clinical and research environments? And what potential benefits to the lymphoma community do you see going forward?
Currently in my research, I have not. I know that there's like VA GPT, where it's a local system and it's not connected to the internet. And I know that our VA in like Salt Lake City is doing a lot of like machine learning and AI tools. So there are people who are much smarter than me in terms of those technologies that are probably doing this. In terms of clinical work, I have been using open evidence sometimes, and that kind of helps me gather tools and publications, and just to review it. I don't necessarily like blindly follow anything. It has to kind of take the patient into consideration, of course, the evidence available, what's covered by the VA according to our guidelines, and kind of take everything into consideration with the patient before making any decisions.
Dr. DeStefano, Dr. Helmer, anything to add to that end?
I'm not using it in research or clinically outside of on occasion open evidence, but it's definitely coming and it's going to be exciting.
So we're doing some research applying AI to the VA's electronic medical records and trying to use it for identifying cases. In particular, I'm looking at Gulf War illness, which doesn't have a diagnosis code, so we can't use the structured data. So we're using natural language processing and really trying to sift through all of the all of the words and all of the notes, and we're trying to use some AI, some large language models to make that more efficient so that we can identify that. I do think that sort of use case could be helpful. Even in cancer cases, especially when we get into looking at exposures. So for example, it's been very hard to, even though we have a burn pit registry, so we didn't talk about that today, but there's a burn pit registry, VA, Department of Defense, and there were 500,000 people who completed an online questionnaire, which is great. We really appreciate people taking the time to do that, but now we've got a denominator file of everybody who was deployed after September 11th, 2001, anywhere in Iraq, Afghanistan, or the surrounding areas. And that has 3.7 million people in it. And we'd really like to establish with more certainty where they were when they were there, and a few more details maybe about their occupational specialty, and then apply some model-based particulate matter exposure to that entire cohort. And so that's going to take a little bit of what I think of as magic, and definitely, we're going to have to do some of the AI and some of those other big data science approaches to making sense out of all of that. And then the whole goal of that is that then we have a platform for looking at the health outcomes and kind of narrowing in on different segments of that broader population to explore, health outcomes that might be related to specific locations or units or jobs, or even if we have some of the toxin information, that we could incorporate that as well.
I appreciate all of you for speaking to that topic. I think it's really top of mind for patients kind of on every program that we have. So I really appreciate your input. And it looks like that's the last question we have time for today. Before we wrap up, I, of course, want to thank all 4 of our speakers for their time. And I also want to thank all of our attendees for joining us for today's program. If you have any additional questions, or if you'd like to be connected with someone else who's been impacted by lymphoma, you can always reach out to our helpline. That number is all over lymphoma.org, but it is 800-500-9976. And if you prefer email, that's helpline@lymphoma.org. I know we got a few questions about specific clinical trials today. We do have a clinical trials information service, and our helpline staff can conduct kind of a personalized search for you based on what you're looking for, so and what you might be eligible for. So please do visit us at lymphoma.org, where you can find information about that. But thank you so much again, and I hope you all have a great rest of your day. Take care.
Thanks.
Bye, everyone.